All right, good afternoon, everybody. I think we should start this session on emergency radiology in oncologic patients, challenges in diagnosis and treatment, related complications. We have three speakers for today. The first speaker is Jasmina Boban, a neuroradiologist at the Oncology Institute of Vojvodina, Serbia. And she will talk to us about acute CNS conditions.
Thank you very much. It's my great pleasure to be here in this beautiful city of Athens. Thank you to the organizers for invitation. What I will deal with in today's talk, I will try to present some interesting cases that we encountered in the last few years. We all know that modern oncology is associated with a lot of movement towards personalized medicine. So we are trying to treat every patient in an individual manner. We now have a whole palette of different treatment modalities, including chemotherapy, including immunotherapy, and including some novel personalized treatments, such as genetic therapy. Neurotoxicity related to chemotherapy is a classical thing. In the peripheral nervous system, it's completely dose-dependent, it's persistent. We all know from the practice that it can last for several months, even for several years after discontinuation of the chemotherapy. Central neurotoxicity, to the contrary, is not dose-dependent. It's a bit individually tailored. So it is something that we are not sure whether will happen or will not happen. It is variable in its symptoms, it is variable in its severity, but it is not an uncommon condition, and we should bear it in mind when treating the patient and when evaluating the images. So the mechanism of the central nervous system neurotoxicity in chemotherapy is dual. One is direct toxic effect to the neuronal tissue that is related with vascular injury and ischemia, and the other one is due to systemic therapy. So don't forget about the metabolic disturbances and also about hepatotoxicity that has the indirect influence on the neuronal tissue. We know very well from the literature the neurotoxicity of several agents such as methotrexate, ifosfamide, or citarabine. The symptoms vary from only fatigue, headache, which is very common, to cognitive deficit, seizures, cerebral dysfunction, and also psychiatric symptoms. It can be presented in the acute fashion, subacute fashion, but also in delayed. So don't forget, even few weeks after discontinuation of the therapy, you still can have symptoms of central neurotoxicity. This is a case of a 9-month-old female with neuroblastoma stage 3. She has a rapid alteration in mental state, going to coma 7 days after start of induction chemotherapy that consisted of cisplatin, vincristine, and anthracycline. What we can see, so what we can see on T2, I will switch to the laser pointer. I think it would be easier for all of us. Like this. Do you see it? Yeah, perfect. On T2, we barely see anything. On FLAIR, even less. But on diffusion-weighted imaging, we can see areas, ill-defined areas in the subcortical and deep white matter on both sides, but predominantly on the right, with restricted diffusion. And additionally, we can see diffuse leptomeningeal enhancement. This is a typical case of acute leukoencephalopathy with restricted diffusion. This condition is very severe. It has severe neurological presentation, and it also can have severe neurological consequences. It starts hours to days after initiation of chemotherapy with disorientation, confusion, and agitation, and it has potential progression to coma. Usually it's referred to acute leukoencephalopathy with acute subacute leukoencephalopathy with reversible diffusion-weighted imaging pattern. Sometimes it can also present with seizures and hallucinations, and the main differential diagnosis will be epileptic seizure or metabolic disorder. The MRI presentation is as I showed you, so diffuse abnormalities of diffusion located in deep and subcortical white matter. The recovery is usually at least partial, or complete, but sometimes it can also lead to death. Impaired cognition is a common neurological sequela. This is the imaging of this child 3 months after this episode. What we can see in the images is that the lesions, the restricted diffusion is completely gone. So we see that the ADC maps are almost normal, but also appreciate these areas of T2 hyperintensity around the occipital horns and the overall global atrophy that has occurred in the meantime. The common agents that cause this condition are methotrexate, especially when applied intrathecally. So it alters the myelin synthesis. So basically, this is demyelination in its pathophysiological mechanism. Citarabine and also ifosfamide, they are also toxic to the oligodendrocytes. So in the mechanism of this condition, most probably is a kind of toxic demyelination. Citarabine has a dose-dependent neurotoxicity. So this is the agent where we know when we can expect neurological deficit. And L-asparaginase with metabolic encephalopathy that is more commonly using ischemic or even hemorrhagic strokes. Another patient, a 51-year-old male with pancreatic cancer. He's treated with platinum-based chemotherapy, presents with severe headache, progressive vision loss, and mental state alteration, going into soporous state in the first week after chemotherapy. What we can see is, again, ill-defined area of restricted diffusion that affects visual cortices, optic tract, and goes to the corpus callosum. On the T1 non-enhanced images, we can see hyperintensity at the level of the transverse sinus. After application of the contrast, we can see that there is filling defect in the transverse sinus on the right and also in the whole superior sagittal sinus. So this is cerebral venous thrombosis related to cancer and cancer treatment. Patients with malignant disorders have around 4 times higher risk of venous thrombosis, and we know that about 1/5 of the cancer patients will develop either deep or superficial venous thrombosis. In cerebral venous thrombosis, the cause, the etiology is related to cancer in around 7% of the patients, and it can be due to local factors like compression of the tumor or to systemic factors due to hypercoagulable state, partially caused by the paraneoplastic syndrome or the cancer, and partially also caused by therapy. So cancer will promote the cerebral venous thrombosis in 2 ways. The risk of major hemorrhage in cerebral venous thrombosis and also the recurrent state or the rest of the tumor thrombosis, as well as risk of death as a primary outcome, is several times higher in oncologic patients. What are the mechanisms? For some agents, we know the mechanisms of thrombosis, and for some, we don't. In the center, you can see different mechanisms. So whether there is reduced anticoagulant activity, whether there is activation of the platelets with increasing procoagulant activity, or local factors such as endothelial dysfunction or again increased platelet activation, they all can lead to thrombosis in several ways, and there are agents that can promote coagulation in several different mechanisms. So these are considered highly thrombophilic agents. Let's go on with the cases. 27-year-old female with multiple myeloma. She was treated with bortezomib, one of new immunologic agents, dizziness, ataxia, and profuse vomiting 2 days after immunotherapy. These are the images. On this sagittal flare image, we can see the edema located at the level of the cerebral cortices. So mainly, we have edema at the level of the superior cerebral hemispheres, a bit also on the caudal parts, and the Vermean part of the cerebellum with clear restricted diffusion. This is referred to as acute cerebellar syndrome. It was first described with citarabine in the 80s, and now we also have some data on monoclonal antibodies and proteasome inhibitors. So the new therapies also can present with acute cerebral syndrome. The symptoms are related to the posterior fossa, dizziness, ataxia, troubles with the pronouncing words, vertigo, and nausea and vomiting. The MRI can be normal. So the patient can present with acute cerebral syndrome, but without any findings on the MRI. If there are findings, this case that I showed you is the typical one. So the white matter lesions in the infratentorial compartment that actually indicate the acute toxic encephalopathy with restricted diffusion. The recovery from this condition is uncertain. Sometimes it is complete, but sometimes it can also leave global cerebellar atrophy that is associated with prolonged symptoms. 41-year-old female has colorectal cancer. Cancer treated with FOLFOX regimen, so 5-fluorouracil, leucovorin, and oxaliplatin, presents with anorexia, fatigue, dizziness, and also confusion, acute confusion, 1 week after receiving chemotherapy. This is a classical case. So we can see a round lesion, relatively well-defined, located in the center of the splenium of the corpus callosum with restricted diffusion. It used to be referred as MERS, so mild reversible encephalopathy. Now we refer to it as cytotoxic lesion of the corpus callosum. This is a rare manifestation of neurotoxicity, but it may happen. It's a small lesion, but usually has very severe clinical findings. It happens within days of initiation chemotherapy, and we now know that for this cytotoxic lesions of the corpus callosum, the main factors are actually individual factors of the patient. So it is not dose-dependent, and also many agents can cause it. 5-fluorouracil is one of the classical ones, but also it can happen with all kinds of immunotherapy, chemotherapy, or some supportive drugs that might be used. What can be done here, because you have to discontinue the therapy, and is suggested, is actually assessing dihydropyrimidine, dehydrogenase enzyme activity in the patients, and according to the results, the clinician will change the regimen of the therapy. It's usually reversible. Sometimes it can also leave a bit of gliosis. Another one, 55-year-old male. He presents with palatal tremor, disorientation, and progressive mental state alteration 3 days after intrathecal therapy with methotrexate and cytarabine. So he has two chemotherapeutic agents that are known to be related with central nervous system neurotoxicity, and additionally they're applied in a manner, so intrathecally, that is highly risky for neurotoxicity. He was heavily pretreated for acute lymphocytic leukemia. What can we see? There are bilateral, completely symmetric lesions, almost like in the mirror, located at the dorsal parts of the brainstem. So we can see that the dorsal tegmental tracts are involved. Additionally, we have bilateral involvement of the superior cerebral pedunculi, and also a bit of edema located in the optic tracts at the level of the mesencephalon bilaterally. There is no restricted diffusion. We can see disturbance on B1000 images, but no restricted diffusion on ADC, and completely no contrast enhancement. These are dorsal tegmental tract lesions. In children, this would be referred to as dorsal brainstem syndrome, and it is associated with hypoxic ischemic injury. What we can see are isolated bilateral, strikingly symmetrical lesions in the brainstem tegmentum, so pons and medulla oblongata. There are reactive lesions, secondary lesions, so the same as cytotoxic lesions of the corpus callosum. And we think that the mechanism is actually associated with vascular supply and ischemia, because this is a watershed vascular territory, so it is underrepresented by anterior circulation and basically almost completely dependent on the posterior vertebrobasilar system that we know is, let's say, locus minoris resistentiae for autoregulation. So the etiology would be probably vascular or hypoxic. What about immunotherapy? Immunotherapy brought revolution to the treatment of the cancer patients. We now see the full waiting rooms of patients with melanoma, which was not the case when I started working almost 2 decades ago. So neurotoxicity related to immunotherapy has to do with the immune system of the patient. The immunotherapy will enhance the immune system of the patient in order to detect and destroy the cancer cells. So we are trying to boost the immune system and to, let's say, enhance the natural defense from the cancer. There are several drugs, several types of drugs that can produce neurotoxicity, and these are referred to as immunotherapy. The first and the best known ones are immune checkpoint inhibitors, such as PD-1, PD-L1, CTLA-4. They have rare but serious adverse effects in less than 1% of the patients. Why do we image them? Because these are the patients that are usually treated for metastatic cancer, and the differentiation towards malignant disorder from the immune therapy-related neurotoxicity is sometimes very hard. How do they present? So these serious adverse effects include meningitis, encephalitis, acute demyelinating disorders, vasculitis, neuropathies, neuromuscular junction disorders, and myopathy. Encephalitis in these drugs is a bit more commonly reported, such as with nivolumab or ipilimumab, but also vasculitis is not so very rare. It's a very huge differential challenge towards the paraneoplastic syndrome, so these will be the diagnosis of exclusion. The other group is immune effector cell-mediated neurotoxicity, or the ICANS. This is something that happens quite often, let's say. It is associated with CAR T-cell therapy and BiTE antibodies, so in hematologic malignancies. They say that more than 1/2 of the patients receiving this therapy will develop some neurological symptoms several days after infusion, usually lasting up to 2 weeks. These neurological symptoms are mild, and usually the patient is not hospitalized for that. However, sometimes they can also produce acute toxic encephalopathy, encephalitis, or meningitis, and these are considered to be adverse effects. They are not so common. They occur in up to 5% of patients. They're usually progressive, so they start as word-finding difficulties, fatigue, maybe some headache, and then they progress to aphasia, motor deficits, mental state alteration, and cerebral edema. Another group of drugs are monoclonal antibodies. They are rarely associated with neurotoxicity at the level of the case report. Usually it's headache, insomnia, dizziness, so some mild symptoms. And the last one are the antibody drug conjugates, completely new drugs, at least in my country. So these are combining cytotoxic drug or targeted therapy with monoclonal antibodies. So we are killing the cancer with cytotoxic treatment and also boosting the immune response. So trying to hit the disease from 2 different aspects. The incidence of serious adverse effects in these drugs expectedly will be up to 10%. So they don't cross the blood-brain barrier efficiently, but cause peripheral neurotoxicity. However, in some cases, when the blood-brain barrier is disrupted, especially with irradiation, we will have also the central nervous system toxicity. They rarely cause encephalopathy, intracranial hemorrhage, or Guillain-Barré syndrome. We have a case here to show you. So 52-year-old female, metastatic breast cancer. 10 days prior, she received trastuzumab and deruxtecan. And since 3 days, she has rapid neurological worsening with altered mental state. What we can see are multiple lesions in the white matter, including the subcortical parts, with edema, with some contrast enhancement, with a lot of hemorrhage internally, and without clear restricted diffusion. This is cancer therapy-associated posterior reversible encephalopathy syndrome, or PRES. This is more frequently reported with platinum-based chemotherapy, so this is something that we already know. It's probably caused by the blood-brain barrier disruption and also endothelial toxicity. That is why it is associated with platinum-based drugs. Additionally, these drugs cause the fluctuation of the blood pressure, and this is especially related to the posterior reversible encephalopathy syndrome. It's more common in females. It presents with seizures, with alteration in the mental status, and it's usually reserved for the posterior circulation. Most of the cases that were described in literature were associated with rituximab, cyclophosphamide, doxorubicin, vincristine, and the platinum-based chemo treatment. Hemorrhagic PRES is presented by catastrophic neurological deterioration. We only have a few cases reported in the literature, and usually after heavy chemotherapy. Remember that these antibody drug conjugates are actually the drugs that are used in the patients that already have uncontrolled disease for some time. The severe progression is rarely seen with breast. Breast is usually reversible, usually is resolved in a few days. However, if there is intraparenchymal hemorrhage, that is believed to be due to individual factors of the patient that make him prone to hemorrhage, and this is much bigger problem to treat. It usually ends up fatally. Pathophysiology of hemorrhagic transformations is not fully understood. There are several mechanisms that are proposed, such as reperfusion injury, cerebral vasospasm and extravasation of the red blood cells, and also direct neurotoxicity to cerebral blood vessels. The conversion rate is not so low, so it's more than 10%, and it will range from focal hemorrhage, convexal sac, to cerebral microbleeds that are detected only on SWI. Also, another proposed thing to look at, which I found in the literature, are the vascular anatomic variants, so the predomination of one or other side in the circulation. So to sum up, and to finish the talk, I will raise some common concerns that we have. So if you have the new onset of neurological symptoms, of course, always consider cancer spreading to the CNS. In these cases, if you do CT, you will have low sensitivity. Probably you will deal with leptomeningeal metastasis or parenchymal metastasis or pachymeningeal metastasis. In some of these cases, CT will not be sensitive enough. So my recommendation is to go to the MRI and clear this up if you can, if you have this opportunity. Additional PET or the lumbar puncture sometimes can give you additional insights whether we are dealing with inflammation or with or with infection. Paraneoplastic syndromes are not that common, so they occur in less than 1% of patients with solid tumors. They're even less common in patients with hematologic malignancies. Don't forget the comprehensive history taking and the clinical examination. With this, I would like to end my talk and to thank you for hosting me to this event. Thank you.
Thank you very much, Professor Boban, for an excellent talk and very interesting case presentation. Any questions from the audience, please? All right, I have a question for you. We do know that MRI is the gold standard for following these patients, of course. In your department, do you triage everybody to MRI, or some of them will get a CT first in order to alleviate your workflow? And is there a role for MR spectroscopy in this setting?
Thank you for your question. Sometimes it depends on the state of the patient. We try actually to do the MRI when we have the acute neurological worsening of the patient. We try to do the MRI. However, it's not always possible due to fast tracking, due to enabling the workflow, the smooth workflow. We sometimes refer them to the CT. Sometimes the CT will solve the problem. In the cases of intracranial hemorrhage, in the cases of acute ischemic stroke, but usually in the cancer patient, we like to see the MR, we like to see the leptomeninges and the potential spread towards the CNS. And the second question, the MR spectroscopy, we are a center that is quite experienced in MR spectroscopy. Sometimes we do it, but not in the setting of the acute situation.
All right. Well, thank you very much.
Thank you very much. I wish you a fine continuation of the Congress and to learn a lot.
Thank you very much. All right, so the next speaker for today is Giorgio Masci, whom I do not see in the audience. All right, so we will proceed to the third speaker, which is Harina Triantopoulos, radiologist and chair of the Department of Radiology at Nea Ionia Konstantopoulou General Hospital, and she will talk to us about acute abdomen. Harina, please.
Καλημέρα. Η ομιλία θα πρέπει να γίνει στα αγγλικά προς τιμήν των προσκεκλημένων ομιλητών μας. So we all know that a patient with advanced cancer present quite often to the emergency departments, and some of them are frail and acutely ill. On the other hand, from the newly diagnosed cancers, almost 30% are emergently diagnosed cancers, and these people have a poorer quality of life. In this table, we can see the cases that are diagnosed on an emergency basis, and the vast majority is related to tumors of the GI tract and tumors of the solid abdominal organs. So the emergency are related either to undiagnosed cancers, to paraneoplastic syndromes, to complication from the cancer, and to complication from the different types of treatment. We'll start discussing some selected abdominal emergencies, starting by hemorrhage. So about 15% of patients with hepatocellular carcinoma may present with abdominal hemorrhage. The same could happen with the spleen when it is affected by lymphoma or leukemia. There are three important risk factors for hemorrhage that are the large size of the mass, the subcapsular location, and the increased vascularity. The mechanism behind the possibility of hemorrhage are the direct vascular invasion, the increased intratumoral pressure, and the venous congestion. So it is easy to recognize acute hemoperitoneum by the high attenuation ascites on non-contrast CT. Later on, when clotted blood is formed, we can see a higher attenuation, and of course the sentinel clot may indicate the source of bleeding. But of utmost importance is to recognize the active extravasation of the contrast that indicates ongoing bleeding, and of course there is need for embolization. So this is a typical case. We can see the active extravasation of the contrast in the right colon, and this is a typical case in a case of right colonic cancer. This is another case. There is a rupture of a hepatocellular carcinoma in the liver segment 4, and we can see the high-density ascites. A case of splenic rupture, it was a case of splenic lymphoma. We can appreciate the large size of the spleen and the many lymph nodes in the porta hepatis. Now about intestinal emergency. There are two main emergencies, the acute intestinal obstruction and the perforation. 30% of colorectal carcinoma may present with acute intestinal obstruction, while 10% of colorectal carcinoma may complicate by perforation. There are also metastases that may complicate with small bowel obstruction. Concerning perforation, the reason is the erosive tumors, the bowel ischemia, and sometimes the long-standing obstruction. So these are typical cases of bowel obstruction from sigmoid carcinoma, very well evaluated on coronal CT and sagittal MRI. Of course, we know that on an emergency basis, we may perform plain X-ray. In the supine or erect position, we can recognize obstructive ileus, and then we go to CT to evaluate the level of obstruction, the transition zone, and the reason behind it. So this is a case of small bowel obstruction because of colonic carcinoma. As you can see, there is dilatation of the small bowel, and it is important to emphasize that when the diameter is very big, there is a risk for perforation. So this was a very rare case, a patient with pancreatic cancer. He presented in the emergency department with obstruction of the stomach. This is not quite common. Usually this patient presents with obstructive jaundice, but it was the reason of infiltration of the duodenum, and so it was a rare case of firstly diagnosed pancreatic cancer. So now concerning perforation, on CT we can see, of course, the free intra-abdominal air. we can see the extravasation of the contrast, and of course we can locate the site of the disruption here in the small bowel. Another case of bowel perforation and the formation of an abscess in a case of a large pelvic cancer. This was a more complicated cases because we had obstruction together with infection, a colonic cancer disseminated to the abdominal cavity with peritoneal infiltration, lymph nodes in the porta hepatis, and the dilatation of the bile ducts together with small abscesses. Let's move now to ischemia. Up to 7% of patients with colonic carcinoma present with ischemic colitis. But the most serious complication is the mesenteric ischemia that could be caused when we have mesenteric root metastasis or infiltration of the mesenteric vessels from pancreatic adenocarcinoma. It is important to differentiate between the ischemic bowel segment from the tumoral segment, and this can be done on CT. Because the ischemic segment is characterized by circumferential wall thickening, and thickness does not exceed 1 centimeter, while in the tumoral segment there is asymmetric wall thickening that exceeds 1 to 2 centimeters. What about intussusception? In adult population, almost 50% of the cases are related to neoplastic etiology. Primary and secondary bowel wall tumors may complicate with intussusception. On CT, we have the typical signs of bowel within bowel appearance, with or without incorporation of fat and vessels that may confirm the diagnosis. So remember that in cases of adult intussusception, we should first of all exclude bowel cancer. Concerning the urinary tract, pelvic cancer and retroperitoneal malignancy may complicate it either with bladder outlet obstruction or with ureteric obstruction. And this is done either by extramural compression or direct tumoral invasion. Concerning imaging, the main methods are the multi-detector CT urography and MR urography that may help us not only to locate the level of obstruction, but also to define the cause and also propose the proper method of treatment, either is a percutaneous nephrostomy or an ureteric stent. So this case was evaluated both with CT urography and MR urography. It was a case of a lady who underwent surgery for ovarian carcinoma. We had a stop at the level of the distal third of the ureter, and of course this was a stenosis after surgery and not a disease relapse. Now, acute bacterial cholangitis is related to biliary obstruction because of pancreatic cancer or biliary cholangiocarcinoma. It is important to locate the level of the tumor, and of course, concerning the findings, we can see concentric wall thickening with enhancement, hepatic parenchymal changes, and arterial hyperenhancement, which is typical, wedge-shaped, peripheral, or peribiliary in distribution. Complication may include vein thrombosis, hepatic abscesses, or infected biloma. So this was a case of acute cholangitis. It was a case of pancreatic head cancer. We can see dilatation of the bile ducts and the typical wedge-shaped hyperenhanced areas in a peribiliary location. Now let's move to treatment-related emergencies. Cisplatin is a cytotoxic drug that is used in treatment of many cancers. unfortunately, it predisposes the patient to thromboembolic events, and we can see thrombi in many abdominal vessels. About monoclonal antibodies like bevacizumab, this may complicate with spontaneous gastrointestinal perforation, and we have patients also who undergo radiation, and we know that there are two major complications, the acute enteritis, and in the later stage, the urinary tract obstruction. So bowel toxicity for chemotherapy is a serious event. Chemotherapy erodes the intestinal epithelium, and colitis occurs within 5 or 8 weeks of initiating the treatment. As we have mentioned before, the monoclonal antibodies can lead the patient to bowel perforation. You see that the risk is 1.7%, but the mortality is quite high, almost 1/4 of the patient. So there is an increased risk of perforation at the site of an infiltrating or ulcerating neoplasm. And of course, CT findings are well known. There's the pneumoperitoneum, the extraluminal contrast, and potential fistula or abscess formation in the future. Now, what about immune checkpoint inhibitors? We know that immunotherapy is used last year, and there are well-recognized immune-related adverse events that can affect particularly every organ. But the most serious and the most common complication is colitis that presents with the bowel wall thickening, engorged mesenteric vessels, and pericolonic inflammation on imaging. Hepatitis is another very important side effect of immune checkpoint inhibitors. We have subtypical imaging findings, and this may lead to discontinuation of the treatment. Otherwise, liver failure may occur. So again, this is a case of colitis in the right colon as a result of cytotoxic treatment. And this is a case of hepatitis evaluated on MRI. We have the contrast technique and the diffusion technique, and we see the typical periportal edema that characterize the first stage of hepatitis. This is another case of a very rare disease. It is a vasculitis caused by, again, immune checkpoint inhibitors, and we can see this abnormal tissue that is formed around the major vessels, the porta hepatis, and the superior mesenteric artery. Now, what about radiation? There are mucosal changes that occur in 90% of patients that are exposed to radiation. The terminal ileum is vulnerable because it's fixed position. What we can see on CT is bowel wall thickening, submucosal edema, mucosal hyperenhancement that may progress to ulcers and hemorrhage. Differential diagnosis should be done from Crohn's disease, enteric metastasis, enteric lymphoma, and mesenteric ischemia. But we know that the radiation damage is focal and affects only the areas that are directly exposed to the radiation. In the later stage, we may have some complications like strictures, fistulas, and impaired peristalsis. So this is a typical case of radiation. Radiation enteritis that affects the terminal ileum. Patients who underwent transplantation may suffer from the well-known graft versus host disease. And the small bowel is involved in almost 75% of the cases. Again, the CT findings include the focal or diffuse small bowel thickening with or without mucosal enhancement. We know that this patient may suffer also from neutropenic, pseudomembranous, and CMV colitis, but this disease affects the colon and not the small bowel. which is usually affected in this disease. And this is a case from the literature. We can see that all the small bowel is affected together with a small amount of ascites. Abdominal compartment syndrome is another very serious complication. It is related to intra-abdominal hypertension, and it can develop in critically ill oncologic patients because of advanced disease, large tumors, severe ascites, or bulky lymphadenopathy. What we can see is the so-called round belly sign, meaning increased anteroposterior to transverse diameter, like in this case here of disseminated peritoneal disease with ascites. And in this case, we may see compression of inferior vena cava. But inferior vena cava syndrome may also be related to deep vein thrombosis, invasion, or compression of the inferior vena cava. On an emergency basis, of course, we use ultrasound to recognize the disease, but we should go to CT in more stable situation to visualize the thrombus, the tumor involvement, and any signs of abdominal congestion. So this is a very interesting case. We notice on this CT a hypodense lesion inside the inferior vena cava, together with thrombosis of the left renal vein. And going to PET, we recognized a very small lesion in the wall of the inferior vena cava that was proven to be a leiomyosarcoma. Okay, reaching the end of this lecture, I would like to share a nice case with you, just to show you that an emergency situation may reveal but may also hide a tumor. So we had a 75-year-old man. He presented with intense abdominal pain. He had a history of acute pancreatitis 2 times before. And on ultrasound, we saw enlargement of the body and tail of the pancreas. Concerning laboratory results, there was increased level of glucose and lipase with normal levels of amylase. Next technique was MRI that was performed. And these are some selected images. You can see the T2 with increased signal intensity. Then we have intense contrast enhancement. And on this diffusion technique, we can see that there is a restriction of diffusion in the body and the tail of the pancreas. But we had no evidence of a tumor or something else. So there was a laboratory investigation for IgG4-related sclerosing disease that was negative. Other reasons for acute pancreatitis were excluded. So as the patient had a favorable clinical course, he was discharged from the hospital, and it was planned a follow-up MRI after 3 months. But the patient came 10 months before, something that may happen, and he was complaining for abdominal pain and weight loss. So now we had CT. This is the CT early arterial phase, late arterial, and portal venous phase at the level of the head, nothing remarkable. And the level of the neck, again, nothing remarkable. And at the area of the body and tail. What we can see now, and differs from the previous imaging 10 months before, is that now the pancreatic body and tail are atrophic, and maybe there is mild dilatation of the main pancreatic duct. We moved to MRI, and what we can see now is that there is a marked restriction, not in the body and the tail of the pancreas, but now in the head of the pancreas and in the neck of the pancreas. Nothing remarkable on T2 except the mild dilatation of the pancreatic duct, but on coronal imaging maybe we can see that there is a lesion that looks like a tumor in the pancreatic neck. Of course, endoscopic ultrasound was the next test, showed a hypoechoic, hypovascular mass in the pancreatic neck that was extending to the splenoportal confluence, and of course the FNB showed that it was a low differentiated pancreatic adenocarcinoma. So going back, I think now we realize that the tumor probably was already there, but it was hidden by the complication of acute pancreatitis, and now we can clearly see the tumor at this area many months later. So remember that acute pancreatitis is an early symptom of pancreatic cancer. We should never neglect a small area of restriction in diffusion, even if we cannot see in the other sequences. And we need to add a delayed phase to pancreatic and portal venous phase, because this may help us to increase our sensitivity to reveal small pancreatic adenocarcinoma. And again, the first complication could be acute pancreatitis. So in conclusion, oncologic patient may present with acute abdominal condition due to cancer itself, to treatment side effects, to complication, to immunosuppression, or to infection reactivation. Some of this emergency could be life-threatening. It is important for us, first of all, to know the current treatment options, their possible complication, and to make a timely diagnosis so that to improve patient care. Thank you very much.
Thank you very much, Dr. Triandopoulos, for a very detailed talk. Any questions? All right. I would like to ask you, you mentioned colitis after radiation therapy in the pelvis. Because we do see a lot of radiation cases for women with cancers of the pelvis. And often we do see this thickening of the bowel wall and the mucosal enhancement and so on and so forth. That is a colitis, but the patient is clinically asymptomatic. Mm-hmm. Do you agree with that?
Yes, sometimes there are no typical symptoms. In most of the cases, of course, maybe there are diarrheas or other symptoms of low abdominal pain. The question is if we need to report on these findings and to attribute them to the radiation treatment. It depends on the severity. Sometimes there is just a slight thickening of the mucosal wall, which is not a serious adverse event and may not cause symptoms, but when there are ulcerations, which could be another complication, in this case, I think we will have more prominent signs and probably symptoms will occur the next days.
Also, this case of the splenic rupture in your lymphoma patient was very interesting. Was that suspected before imaging, or it was an imaging finding?
No, unfortunately not. It was a sudden event. We don't know. We thought at first it was, of course, after trauma. So it was not spontaneous. It was a trauma, but the patient didn't know that lymphoma was already there.
All right. Thank you very much.
Thank you.
Is Dr. Masci anywhere in the audience yet? No. Well, unfortunately, then we will have to cancel the third lecture, and thank you all very much for being here. Thank you.